today. So today we're going to talk about, oh, sorry, we're going to talk about ideas. So let's start with basically when we talk about ideas, that's one of the three I's. We have the institutions, we have the interests, and we have the ideas. Last week we talked about institutions. Today we're going to talk about ideas, whereas next week we'll talk about interests. So for today, we're talking about ideas. And then when we talk about ideas, what does ideas mean? So ideas basically incorporates both knowledge and values. So it has the knowledge components, it has a value component. And when we talk about knowledge, knowledge simply means talking about what is, whereas value talk about what ought to be. And when we talk about what is, that's it's basically about what the evidence tells us based on the research evidence, based on tacit knowledge and experiential knowledge. And when we talk about tacit knowledge, these are let me ask, what do you understand by tacit knowledge? I want to make a conversational. Tacit knowledge. Oh, these are like these are kind of sort of knowledge that we have, people have, not necessarily informed by research, not necessarily informed by core research. It's a kind of belief system that we have. Okay, Julia, I want to talk. Okay.
How factoids and like that kind of influencing what people think is knowledge. Um, when in reality, it's just kind of like fake information that's kind of been spread like consistently, to like kind of create an idea as like knowledge.
Yeah, basically it's about what in terms of trying to what is understood or implied without actually being stated, kind of a belief that we have, even without saying it. Well, it's a belief that is held. So when we say something is tacit knowledge, that's having like a sort of notion that it's difficult to express. There's something that we know that it's kind of difficult to express. That's you can raise your hand, stranger. Oh, yeah, exactly. Implicit knowledge. So it's often not easily communicated or difficult to explain or express, but it's a kind of implied knowledge that we have. Yeah. And then the other aspect is the about what ought to be. First is about what is, or this is what we know. This is what we expect things to be. This is what the research or evidence tells us. This is what the available knowledge tells us. This is what may be proved or might be provable based on available evidence. And then there's also, then another aspect, which is what ought to be. Then when we talk about what ought to be, that's when we talk about values, that's when we talk about norms, moral positions, ideologies, philosophies. So the first one is, yeah, this is what is provable, this is what is tangible to some extent. The tacit is difficult to express anyway. And then there's then another part which is about what ought to be in a society, the values, uh, the kind of the ideologies that people hold in the community or in a particular group or society. So they have this conception about how things should be. It's a kind of deep-seated knowledge. Like, for an example is like in the previous lecture, I've talked about in the Canadian healthcare system, there's this deep-seated belief that everyone should have equitable access to healthcare. That's the value. That's how things should be. There's this belief that we should not abandon the less privileged in the society, or those who are not so fortunate in the society. That's the value that the society holds. Just earlier today, I was listening to a speech by Prime Minister McCartney. That was a speech he was delivering in Davos, or he delivered in Davos. So then he also talked about the Canadian values. That's one of the things he talked about, the Canadian values, the values to ensure that everyone gets treated fairly and equitably. So that's a value that we hold. And that's a value that would inform how things are run, how decisions are made, even in the policy table. So, and then talking about ideas and policy making, we've tried to understand what we mean by ideas, which is about the first component, which deals with what is, and the second aspect deals with what ought to be. That's about the evidence and values. See, that's evidence aspect. There's an evidence aspect, and there's also the value aspect. So ideas, and then when it comes to ideas in policymaking, basically policymaking here, like I stated here, depicts the interaction between knowledge and values, and values guide actions. It fuels rhetoric and facilitates and constrains our receptivity to research evidence. And basically what I'm trying to say here is that values, when we are presented with copies of evidence to inform policy, the value of the society will decide which evidence would be selected or is likely to be selected to develop when we want to develop policies. So, for instance, we in the Canadian system, we believe that everyone should have access to healthcare without any constraint based on ability to pay, without any barrier or limitation based on ability to pay. That's the value that we hold. So when there are some policy options presented on and policymakers are discussing what's the likely thing to do, or maybe there is a policy proposal or a couple of alternatives. One may be because of fiscal austerity or some other factors like that. Perhaps maybe we should introduce government budget is lean. Maybe we should introduce some user fees for some services to make things more affordable. And then another aspect may be, oh, there's a way we can have an integrated healthcare system that we can utilize the available workforce and resources without having people to spend any money out of pocket to afford those services. So presented with these two alternatives, you will see that what is most likely going to be adopted based on the Canadian context will be the integrated um, healthcare system solution that does not include user fees because of the values of not wanting to include user fees when it comes to the Canadian context. But let's say in the United States, like one of the videos I'll play in subsequent slides, where one of Dr. Daniel Martin and was in the US Congress. So you see that the two groups with the US folks she being from the Canadian angle, they have different ideas and different ways of trying to address the issue of access to healthcare because of the way their world views, because of the system that they operate, because of the values of these two countries. So that's how value can be very instrumental, very, very, very powerful in determining which policy would be adopted over the other. So, and then there's when we talk this aspect, when we talk about evidence, we've talked about idea having both the knowledge component or evidence component and the value component or the belief component, right? Yeah, so when we're talking about the evidence aspect, there is what we call evidence. When we're talking about evidence, we want to ensure that the policy we are making is supported by evidence. But there's this paper, I put the link there for you to access it. They're basically trying to argue about, like, there's been a heated debate uh, over in the last couple of years where they were talking about whether we should be talking about evidence-based practice in informing policy or evidence-informed practice, evidence-based and evidence-informed. So the argument for Melnick and Newhouse was basically that this terminology, this semantics is introducing issues. It will rather introduce confusions that we should stick with what we know already, which is evidence-based practice. But nonetheless, there are people who believe that evidence-based practice and evidence-informed practice are not exactly the same. So, however, that's not the major focus here. The major focus is about that not just research evidence alone should inform practice and policy and guidelines, but rather we should also put into consideration the clinician's expertise or experience, as well as the patient's preference and values. All these are valuable. So you see, even when we talk about evidence, whether in clinical practice or in the health system policy stage, there is this important component of trying to ensure that we are merging and we are integrating research evidence, what the research tells us, with the players themselves, their values, their preferences. So evidence alone, assuming there was a trial or a trial that was conducted and clinical trial, and we got some evidence or any sort of approach was adopted in a research method was adopted to do a research. Let's assume it was a longitudinal study or a cohort study, and we had a finding. When in the policy circle, what the evidence tells us alone is not sufficient in making policy decision. It's very instrumental, very important, but we must also include the value component to ensure that it is acceptable and it is suitable and it is fit for purpose for that context. Then value, talking about value, they influence all aspects of policy, including, for example, first year I talked about how we define problems. For instance, it could be about when we talk about access to care, let's say, in a case where we are talking about access to care, for instance, we know currently, it's been a perennial issue, this issue of access to care, where this issue of wait times, many persons are not able to access, or a huge chunk of the Canadian population, many do not have access to a steady and consistent family doctor. Many do not have, also even accessing some specialist care, there's been a long queue or long wait list. So trying to define a problem, whether as an access issue, may be seen as that comes from an equity lens. We are trying to argue that, this wait list, this problem we have in the healthcare system about accessing care, from an equity lens, we might try to define the problem as, it's an access issue, it's a wait list issue. And then from another lens about, for instance, individual choice, ability to choose, let's say, should individuals have the choice to make about paying privately for services for instance, we know that Canadian healthcare system is heavily publicly funded and covered. That the system is largely designed in a way that we don't encourage paying privately for services, because it introduces a tiered system where people who have ability to pay are likely to access the care faster than those who do not have the resources. So should we introduce a system when we talk about this access issue? Should we now make an argument about what ability to pay? If you have the ability to pay, that means we should just give you a preferential treatment since you can pay. You should just get access to the service. Or should we maintain the core principles about ensuring that no one has any barrier to accessing care because of their inability to pay? So that's where ideas come into, like, from the core Canadian idea that, we want to ensure that equity lens is maintained. And that's because of the value that we hold dear to us in Canada. And then there's also, apart from trying to define a problem, it's also about understanding the causes or understanding the causes of a problem as well as the likely solution. So here, for instance, I have this example about insufficient resources, assuming is versus waste in government. So like when we talk about waste in government, that means we're talking about efficiency. It's about efficiency arguments. Yeah, the solution to the issue we have, if it's framed in this way, that means the probable way to ensure that we have an efficient system would be to try to cut on it, or we shouldn't increase spending. We should try to cut costs and ensure that resources are managed in a way that the system becomes more efficient. And then, however, if it's seen as, oh, there's insufficient resources, that means if it's defined as insufficient resource problem, that means the possible solution that we want to suggest or recommend or possibly implement would be about trying to increase spending. Then also values also so deeply rooted values are difficult to change. Like we even talked about in the previous classes, and even from the lens of the institutions or how these institutions also are built on values, they are built on the ideas. So that's why all these things, all these three I's, they work together. They are not, they are, yeah, they are not in isolation. They also work together in shaping policy, on helping us understand a policy issue, as well as trying to chart a course to address a policy problem. So invariably, deeply rooted ideas can also kind of create barriers to change. So, for instance, I have this about individual versus collectivity. For instance, when we have this idea that this idea, should people actually look after themselves, or should it be a collective work? For instance, one of the papers the reading for this week also talks about the example of the Eastern Europe, Eastern Christian, East Europe's Christian community or countries, how they have this idea that they don't even think about it. It's something that they don't really think about. It's like it's something that is implicit, that they don't even, it's taken for granted, that they believe that the family, like it is the responsibility of the father to take care of the children. Whereas, so if they don't even they don't even think about, oh, there should be daycare, it should be paid for, all those kind of stuff. But from from the Scandinavians, with their social democratic architecture, they themselves, they believe that something should be done about childcare. There should be a social program for childcare because of different ideas and different orientations. Then I also have this about the role of government versus market. For instance, it's believed that markets brings, from the neoliberal market logic, it is believed that the market automatically corrects itself, creates equilibrium, that the supply and demand would always converge towards equilibrium. So if we allow the market forces to drive to drive the 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 demand and supply of goods and services, eventually the market would meet or will come towards equilibrium. But the problem there is that healthcare, that logic does not really work well for healthcare, because healthcare is an essential service, it's an essential good. One, it's also has far-reaching implications. And people, assuming when one is not able to, the market can, if we just allow the market forces alone, there's a knowledge, or what we call information asymmetry, where the physician, who are the suppliers of the services, they have higher knowledge than the than the demand side, which are the users, the patients. So whereas in the ideal market logic, there's this belief that it is expected theoretically that the demand side, or the consumers would have good knowledge of the services they value and all the information they need to make decisions in the market. But we don't have that in the healthcare system where we have information asymmetry. So automatically, allowing healthcare to work within the market logic from the health economic point of view still would introduce a lot of issues. It will introduce a lot of negative outcome, that there will be issues that even the service producers themselves can manipulate the market and take advantage of the consumers. I hope that's clear. Did you understand what I just tried to explain right now? Okay. All right. So then yeah, so I wanted to play this video. Sorry. So this is about value.
Senator Burr. Dr. Martin, in your testimony, you note that Canadian doctors exiting the public system for the private sector has had the effect of increasing waiting lists for patients seeking public health care. Why are doctors exiting the public system in Canada?
Thank you for your question, Senator. If I didn't express myself in a way that make myself understood, I apologize. There are no doctors exiting the public system in Canada. And in fact, we see a net influx of physicians from the United States into the Canadian system over the last number of years. What I did say was that the solution to the wait time challenge that we have in Canada, which we do have a difficult time with waits for elective medical procedures, does not lie in moving away from our single payer system towards a multi-payer system. And that's borne out by the experience of Australia. So Australia used to have a single tier system, and in the 1990s moved to a multiple payer system where private insurance was permitted. And a very well-known study by Duckett et al. Was tracked what took place in terms of wait times in Australia as the multi-payer system was put in place. And what they found was in those areas of Australia where private insurance was being taken up and utilized, waits in the public system became longer.
What do you say to an elected official who goes to Florida and not the Canadian system to have a heart valve replaced?
It's actually interesting because, in fact, the people who are the pioneers of that particular surgery, which Premier Williams had, and had the best health outcomes in the world for that surgery, are in Toronto at the Peter Munk Cardiac Center, just down the street from where I work. So what I say is that sometimes people have a perception, and I believe that.
So I wanted to pick out in the arguments, I wanted to pick out the values that informed the arguments and counter-arguments from both sides.
Actually, this is fueled in part by media discourse, that going to where you pay more for something, that necessarily makes it better, but it's not actually borne out by the evidence on outcomes from cardiac surgery or any other.
People prefer their system because they know consciously they pay more. No, I think it's because they judge quality and they judge innovation. Ms. Pipes, in your testimony, you noted that more than 42,000 Canadians come to the United States each year for healthcare. Why is that?
Because they find that they're on a waiting list in Canada for too long a period and they feel that their health is at stake. So a lot of people in Canada come to the US for MRIs, CT scans. There are many examples in the media of people like Brian McCreath, who came to the US because he was told by his primary care doctor that he might have a brain tumor, but the wait for an MRI was very long. He spent the $1,000, came to the US, paid out of pocket. You will see advertisements in Canadian newspapers for MRIs, for neurosurgery.
It's pretty fertile ground to market in.
Right.
Dr. Martin, in your testimony, you state that the focus should be on reducing waiting times in a way that's equitable for all. What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
I live 1 hour.
All right, so that's where I'll stop with this. Yeah. So, but one important thing I wanted to understand is we understand the US system. We understand how the US system, there's a lot of public and private players in the healthcare system. Private insurance, healthcare is expensive, extremely expensive, probably the most expensive, even amongst the OECD countries. Last week, I told you guys about what OECD means, right? You still remember? OECD's Organization for Economic Cooperation and Development. That's an organization for high-income countries. And I try to explain what they do and how the policies are also okay. It was not last. It was the first class, right? Or no, it was last week when we tried to talk about the Canadian healthcare system. That's when I talked about it. So essentially, the US is super healthcare is super expensive, and there's a lot of private players there. But in Canada, we have more. The public system controls a large chunk of the market, which is the public system also gets its money largely via the tax. About 72% of the money comes via tax, and then a few are from charitable donations and some of those sources. So essentially, what Dr. Daniel Martin's argument here was basically trying to uphold the Canadian value about that no one should be to have any barrier to accessing care because of inability to pay. So, and then there's issue of wait times, which is still a lot of issue that we recognize in Canada. She did recognize the issue. She didn't shy away from it. She knows it's there. But she believed that what is needed is to reorganize the system in a way that resources are utilized, available resources are utilized more efficiently. Even there's the argument she made with Australia in the 1990s that they moved from a single payer system to a multi-payer system. It introduced even more inequities and more, even the wait time issue didn't resolve. So essentially, the argument from the US, and I liked our last rebuttal here about the number of deaths when they are about the thousands of persons that die in the US daily, annually rather, because of inability to pay for their care. So which in Canada, yeah, there may be delay, but Canada healthcare system does not perform as poorly as US generally. If you look at the figures, Canada still performs better than the United States in healthcare. So that's part of the argument. So I was trying to introduce trying to uphold an equitable system in the healthcare system, for healthcare. In no way, that value in no way creates a substandard care. Canada still delivers high quality care, despite the issues that we know exist. Okay. All right. So talking about say on the values, this chart shows us what Canadians value the most over the past decades. Our healthcare system still remains at the top over the years. Like, and remember in the first class, I talked about how the healthcare system of Canada is a national treasure, something that we value a lot in Canada. So, and that's has been there. It's been on the top for over the past decades. You can see other things that we value. What are the other things that we think we value in Canada? What other things apart that is not in this list that you think Canadians value that is somewhat a national symbol? Anything else? Okay, Gabriel. Hi. Yeah, but the bottom line, that's great. Well, the bottom line is that the healthcare system remains a national treasure in Canada. So, and then also see in the United in Britain, the National Health Service in the United Kingdom is also this is also a national treasure. It's a national value symbol that is so valued in the United Kingdom, even more valued than the monarchy. That's to show you how people value healthcare, especially Canada is a thing of pride. The healthcare system that we have is a thing of pride. That they were in the video that we just played, they were um trying to um make make Dr. Daniel Martin to think about or trying to make us see reasons why Canada should adopt the American style, but she also resisted and reported that no, Canada has it better. That even there are more casualties in the US or fatal mortality rates in the US compared to Canada for avoidable causes or due to avoidable causes. Yeah. So and then still on the values, this value also is about belief, what we believe, or maybe thoughts of what we think of as facts. So in one of the readings, I think that was the Cumming and McIntyre reading, I talked about um what are this what they define as assertions or speculations reported and repeated until they are considered true. What so my question is, do you remember what are those assertions and, and speculations that are talked about? So they are talked about long enough that people begin to believe that they are true, that they are factual. Trying to talk about that, that's the paper on food deserts. What's the term for that? Anyone? Yeah, Julia. Yeah, factoid. Yeah, exactly. Correct. Yeah, I hope you guys read the papers over coming. Yeah, Julia did, so yeah, that's good. I hope others did. All right, so that's factoids. I'm trying to use the food dessert example. So it's about, but factoids are essentially not true. They're essentially not true. So it's just that they've been talked about to so much that people begin to believe that they are true. For instance, the example about the food deserts, how there are food deserts scattered around the United Kingdom. Food desert simply means in an urban, a well-populated urban areas where people do not have access to good or healthy food, that they are not able to afford healthy food or they are not even available on the shelves. So, and that's what, however, the research proves that that's not essentially true. Because even in the better resourced areas, some of the studies show that those richer or more affluent neighborhoods, they still pay more for some of these products compared to what those in the less affluent neighborhoods pay for the same products. They are all available. However, the availability is often a product of the size of the shops because smaller shops may have lesser products compared to bigger shops or supermarkets. But nonetheless, the idea of food deserts scattered around the United Kingdom is a factoid. But however, factoids still influence policies when they are taken and assumed to be true. When they are assumed to be facts, they can steer policy decisions in a particular way. So also how beliefs may change over time, as we also like we talked about this it's going to talk about healthy eating, these ideas about for weight loss, protein, the kind of diet that one should eat, whether proteinous or calorie carbohydrate foods, how the research and evidence has changed over time, and also our beliefs have changed over time. Even the number of the alcohol consumption, like this idea that red wines are also healthy for the heart, whereas some years ago there are beliefs that all alcoholic products are unhealthy. Even smoking, cigarette smoking, it used to be a fashionable thing in the early in the in the mid 19th in the mid 20th century. Even there were advertisements and people who were celebrity figures also smoked, and just in a way to promote it as what is the in vogue, the culturally acceptable thing, what's fashionable and what's nice to do. So, however, with changing in evidence, we've come to see that lung cancer has been associated with smoking, cigarette smoking, and the list goes on and on. So that means what was thought of before, based on insufficient evidence or research, but then it was believed to be true, also changed over time. So obviously, those were factors, but research over time has established what is the truth or what is more factual. So still talking about facts, also the Valerie Ensure and colleagues paper also talked about the what's it called again? The conspiracies, especially during the time of COVID. But this video I'm just playing here, which is kind of comical anyway, to some, but just trying to ensure you understand the point. Still talk about how conspiracy theories can also step public opinions and some policies when they are taken as truth. So,
In Springfield, they're eating the dogs. They're eating the cats.
remember this, right?
They're eating the pets of the people that live there. They're eating the dogs.
Yeah, remember that.
They're eating the cats. They're eating
That was during the
the people that live.
during the 2024 electoral cycle in the US.
He's done.
So no, I'll stop here. You have access to the video if you want to enjoy and make fun with it. So, but the idea of this is that it was even established that it was not true. It was established that it wasn't true, that they hate Asians, that they were said to be eating dogs and cats. That was not true. But some persons, especially people who were called Donald Trump supporters, believed the conspiracy and promoted it. So that's the problem with conspiracy theory. And even the paper that we also read about, the Henshaw's paper, Henshaw Valerie and colleagues paper, Valerie Henshaw and colleagues paper, basically talked about how the COVID-19 conspiracy surrounding COVID-19 vaccine, and even the cause of COVID itself, the idea that some believe that it was some elites or some malevolent actors who conspired and caused the whole virus, released it, and for very negative reasons in the bid to harm people, control people, and the list goes on and on. However, and you could also notice that it's also that believing in those conspiracies also shaped their intent to take the vaccine when the vaccine eventually came. Because you see that there was almost 4 times, those who believe those conspiracies were almost 4 times more likely to not want to take the vaccine compared to others. So for a policymaker right now, confronted with this condition, we have a condition where people, during that period, many people were not even sure of, they were trying to understand what is this thing. Even the researchers, the academics, the people who are the policymakers, everyone was trying to understand this new pandemic, this new virus that spread across the world. So there was a lot of confusion. So then trying to make policy as a policymaker, as someone in the policy making situation, or even as someone that would advise policymakers, how would you control or attend to this situation where people have this notion that many persons have this notion that it was caused by some forces and they wouldn't want to take vaccines, whereas a lot of evidence have been shown that vaccines work. At least for instance, the MMR is an example, the mumps, measles, rubella, an example. And there are several vaccines over the years, even the BCG for tuberculosis and some other vaccines. So they have worked over the years, but now people have become anti-vaxxers because of believing in some conspiracies. So this is where we'll talk about values, ideas, information, what is factual, what is evidence, how strong is the evidence, how these things shape decisions, because mostly the policymakers are also conscious of the public opinion. They are conscious of the public mood in making decisions. So, and then,
In spring,
Yeah, so talking about evidence, yeah, we've already talked about even the evidence is there are issues with evidence about publication bias, which we all understand about to publish. Some researchers may choose to publish only the evidence that has been shown to be that has shown positive effects, but may choose not to publish the ones that do not show positive effects. So, and the methodology also, whether it was whether it was well reported and replicable. That's also another thing about research. Can you replicate the study? How well was the methodology reported? And then values and policy. So here about make it faster. Yeah, so values are also about the values can inform us of how to assess the effectiveness of a policy. For instance, how to for instance, using this example, I'll have it, how to portray drinking and driving campaigns. So basically, you want to study the community, study the people. What do they value? How well can you structure how well can you construct the messaging in a way that is appealing and suitable to them? Also about how should you invest your time and resources? So the values of the society can also inform, based on the prevailing evidence, like I've talked about before, how would you invest resources? Even how do you allocate personnel or reallocate personnel or assign personnel to different programs? Where would you invest more money? Where do you invest more time? Where do you invest more financial resources as well? So values can be measured in several ways, like sampling opinions, using structured methodological, even sampling opinions. These are just about ways to elicit evidence because of our research. So, and then just moving faster, because these ones are very intuitive and these are things you know already. You know what these things are. All right, so challenges with measuring values. So people are not always honest in their opinions. So for instance, one may decide to, let's say in a focus group discussion, you see that there's often an issue with the hierarchy where people want to probably try not to say something that may not go well with other people. So some persons may reserve what they would want to say in a focus group compared to an individual interview, where they will have that be free to say their mind without reserving anything, without holding back. So these are part of the challenges about, how do we even elicit good evidence? How do we get real information that reflects that person's core belief, that their real ideologies and their real opinion about a particular issue? So I'll skip this one. It's about levels of evidence. Basically, we know about the levels of evidence from expert opinions at the lowest up to the systematic review of randomized control trials, which, yeah. So challenges in use of evidence for policy. So, so here, issues about lack of available evidence on a particular issue. So an example of a good example of this was the early stages of COVID, where policymakers were, oh, we don't even know what this is. We don't know what to do. They were just, and like ICAM that worked with, we worked with John and Mike, you know what they do, they do rapid evidence synthesis, they do stakeholder dialogues, and the major thing is that they try to produce evidence to support government decisions. That's what I'm talking about is the McMaster Health Forum. So that's basically what they do. They try to produce evidence to inform policy, and they try to hold dialogues to also inform decisions and to get to also ascertain public views about policy issues. So yeah, I also talked about feasibility of implementing the evidence. So what this essentially means, so that if you go back to read the slides, you also understand what I'm trying to say here. So what feasibility of implementing the evidence simply means here is about each context or each jurisdiction or each clime, they have based on available resources, based on even the values that they hold, and even the infrastructure available. About whether they are able to, let's use the example of the infrastructure. Do they have the infrastructure or the resources to even implement the policy? Assuming the World Health Organization introduced or talked about a global way of addressing the pandemic, which we know about anyway during COVID, does the country, let's say a low resource or low income country, may not have even the resources to even preserve, even if they donate vaccines to them, they may not be able to have the infrastructure to preserve the vaccine under the temperature. Maybe it might be electricity, it might be some other logistical issues. So that means with that, having those issues, they may not be able to implement the policy effectively compared to those who have the resources or the capacity to implement it effectively. So then values of policymakers and researchers is also important, because here it's very important that we understand that the policymakers and researchers, it's important that they work together. And for them to work together effectively, that means the values, that's where the value come to play. Yeah, it's also very important to also note that the policymakers, let's say, especially the Canadian government through the CIHR, funds health research, and they will usually fund projects or research projects that are in line with the objectives of the government or what the society wants at that time. Policymakers want to fund projects that fits their strategic plan or their current plan for the society. And then they will also want to fund a researcher that is willing to do the work that they want to do. For instance, there are institutes that we know in Canada that what they basically do is, even within government of Canada, there's this I think it's RPMU, or I need to confirm their name again. Well, basically, what they do is they are the major arm of the Canadian government that funds health research that are strictly for government of Canada. So basically, they know what the government communicates what they want, the kind of research, the kind of evidence that they need to inform the policy that they want to implement. Then they now liaise with researchers who then works on that project on the research to produce evidence to support those research. So, and there are some other institutes also, there are some other bodies in Canada that also what they do is essentially trying to produce evidence. They work closely with the government. They know what the government communicates, the kind of evidence that they're looking for, and they work with them to produce the evidence. So basically, the government would fund such bodies easily. And especially, and when the values also align, it's easier for them to work together, to collaborate. Then barriers to knowledge transfer are basically about lack of information relevant to the needs, lack of awareness of whom to contact. For instance, when you research and you don't actually understand the audience to communicate your research findings, so there's an issue, it becomes a problem to dissemination. Yeah, and then increasing research use in policymaking. So here, basically, I think this one is where the Van de Gogh paper also from there, that's where this was extracted about how to make information to increase the uptake of information, basically about is to ensure that there's easy access to reliable information. They talked about the need for collaboration to ensure creating a kind of atmosphere where the researchers would be able to network and collaborate with the policymakers. Like the example that I talked about with the RPMU, which is a unit of the Government of Health, Ministry of Health, under one of the branches. So basically, that's they connect with researchers and they fund the research that matters very much to the government. And then also another important thing is about working in research receptive organizations. So when you are working with such organizations, it's easy to produce research. It's easy to even get research that are important funded. It's easy to ensure that the evidence you're producing from your research will be easily translated into policy. Yeah. Any question before I just run through this final one? Any question? Any question? I hope that's no, I've gone through a couple of slides without asking any question. If there's anything, please come up, go. Any question at this point? All right. Okay, yeah. So the Campbell paper then talked about the types of ideas. The types of ideas. So the first one is about the cognitive paradigm and the worldviews, right? Basically, these are kind of the taking for granted assumptions of the policymaker, taking for granted worldviews of the policymakers that may actually constrain the policies that will be implemented or what may be acceptable. And oftentimes, we also learn that often uncertainties are what would likely change such worldviews. Only in the case of uncertain policies that are informed by such worldviews, it's usually uncertainties like when there is a shock, when there is crisis or other disturbances, that's often what may produce a change in this kind of ideas. So then the other one is which is also close to this. They use the word the background and the foreground. So another one is also the normative ideas, which are also taken for granted assumptions about norms, about attitudes, identities, and collective shared expectations. So basically, what we've talked about norms a couple of times. We talk what is normative, what is one thing that is very important is to also note is that policy this often plays an influential role, an important role when there is no clear idea no clear evidence of the best policy solution. Then policymakers revert to what the normative ideas. They revert to the normative ideas to inform the policy, the best what could be done. Yeah, we don't know in this particular situation. Let's say in the case of COVID, when COVID happened in the early stages, yeah, there was a lot of confusions. However, we've known over the years that physical distancing had worked in some pandemics. We've known that washing of hands has worked. Even in the case of the previous SARS that happened around 2003, we also know that wearing of nose masks could also help. So it was easy to, we are still trying to understand this new virus, but we can at least take advantage of what we've known previously and what we believe should work. So in the case of confusions, when there's nothing is clear, we don't know what to do, we don't have good evidence to decide what to do, we can revert at least to what is known already. And then frames about is basically about another way of talking about this, about messaging. It's about how we also construct policies in a way that would appeal to the population of interest, trying to construct it in a way that would make it acceptable, trying to construct it in a way, framing it in a way, or reframing policy in a way that will make them acceptable to the target population. And then finally, the programmatic aspect is also about this is more narrower than the worldview, than the cognitive. So basically, this one basically talks about a kind of existing guide, trying to utilize guidelines, precise guidelines to inform policy. How do we, we've known that based on the existing institutions, based on existing ideas, based on what is already we've done before, we can take advantage of what's the existing infrastructure to inform new policy ideas. It gives us like a kind of a framework, a precise framework, especially in the case of clinical. A good example, let's say in the case of a clinical condition, let's say cancer screening, what are the precise guidelines that can be implemented when a new cancer diagnosis has been made? What are the protocols that should be employed? What are the precise ways of going about this particular situation? And then lastly, it's about here. This is second to the last slide anyway, that I'll talk about. The other ones are just so basically about rhetorical use of ideas. So here, the policy paradox by Deborah Stone. It's a nice book that you may want to read. You enjoy reading it. It's a very nice book you want to read. So basically, it talks about how to utilize some devices like metaphors, narratives, like stories. It can be about stories of decline. When we talk about stories of decline, it means, for instance, when we say, oh, a system that used to work, maybe it can be narrated that, oh, the system is going bad, things are not working again as well as they used to work. That's a story of decline. That something that used to work is no longer, it's an assumption that something that used to work is no longer working well or is becoming bad. Things are going bad and going down. Then also, even another example is also about government spending, on how government can also use labelings or use reframe stories in a way, like in the case of the government spending I have here about, oh, the government wants to spend, that spending maybe can be phrased as a bailout. The way the public sees bailout is different from the way they see stimulus package or partnership. So it's the same spending they want to do, but the way they frame it can also shape how people react to the policy. Yeah, so this is the last video I want to play, which is, I think you would want to probably enjoy.
One of the questions that keeps getting raised a lot is whether or not it would be more efficient to have patients pay a portion of the care that they use. The idea being that you eliminate what they call moral hazard, which is if it's free, you're going to use too much of it, and you're going to make people be more careful and cautious about the care that they use. The evidence points out pretty clearly that this is a bad idea. And it's a bad idea for a lot of reasons. First, it epitomizes penny wise and pound foolish. Because yes, indeed, people can be discouraged from making the first visit for care. What they're not that clear is when this visit was necessary or unnecessary. So they found that if you don't get your blood pressure under control, you may have a stroke. It's, over two. It's bad. It's really bad for your health, and it's much more expensive. They found similarly, if kids don't take their asthma medications because they can't afford it, and they end up in hospital with flare-ups of the asthma. So that you have this ongoing issue that the care that you discourage is often the least expensive front-end care, which can often prevent much more expensive complications. The other thing is that most of us are pretty healthy, and most of us don't use a lot of care. So, which sort of stands to reason again, because if you offer me a free pair of shoes, I might say, great if they fit. But if you offer me free open heart surgery, it's very unlikely that I'm going to want to take you up on it unless I need it. So you have this funny thing coming in healthcare, what's called need. And need cuts both ways. If I need it and I don't get it, you probably say I should. If I don't need it, you probably say I shouldn't get it. And there's very few consumer goods that fall into that category.
So I'll stop here. And well, basically, what they're trying to make arguments in support of the Canadian healthcare system, basically trying to uphold the principle that there shouldn't be user fees in the healthcare system, that people should have access and maintain what we have and also improve on what we have, basically, and which is still supported by the values that we hold dear in Canada. And good enough, one of the arguments that was also established is that even trying to maintain the equitable system that we want to have in Canada is also more cost effective, and also not just from the financial aspects, but also apart from cost effectiveness, but also has a net positive in the sense that more persons have access to good healthcare, and the general population health performs better compared to a system that has user fee. Yeah, so I'll stop here right now. Does anyone have any question before we go for a short break and then the presentation?